Our next speaker is Kevin O'Brien. Kevin is a nurse practitioner and clinical investigator at the National Institutes of Health. He's going to talk with us. He has a special interest in serving patients and helping them cope with life with ECD. Yes, this is the laser pointer.
How do I forward the slides?
This or either the button or the mouse.
Okay,
Yeah, this is your pointer.
all right.
Yes.
So I realized that I had the last talk before lunch, so now I'm standing between you and your stomach and the food. So those odds are bad. And secondly, I realized that I didn't put up a disclosure slide. So I'll just say that I have two very fashion conscious daughters in college. So I have absolutely no money to have any financial conflicts of interest. And secondly, I'm an NP, so no one from private industry would be interested in approaching me to get involved in a trial. So I absolutely have no temptations there. So instead, what I think I'll do is I'll pass around a collection basket at the end of the talk. All right. So I just wanted to say that the information that I got from this talk comes from three sources. First, it was the experience of Dr. Estrada and the other physicians that I work with at the National Institutes of Health from running two ECD trials between 2011 and 2018. And as I look around the audience, I see a number of people who were there with me. Second, it's information I also took from the medical literature. And third, a part of this comes from my own experience. So before we begin, there's a couple of important things I want to say. The slides are very information dense, and I don't want you to try to read every word or scramble to take notes, because I've already turned these slides in, and so you will have access to them. Also, I'm going to be hosting the breakout session at 3:15, and we will have the slides there, and then you can come up and ask more questions later. All right, so rather, what I want you to do is just listen to what I'm trying to say, the messages. Look at the pictures that I have on the slides. Let the information just kind of wash over you. If something sticks, if something resonates with you, make a mental note of that, and we can talk about it at the breakout session, and also after the conference is over. I've told Kathy that I'll have free time to speak with people. And lastly, and importantly, that I want to say that this talk is meant to inform you and not to diagnose you. That's the role between you and your doctor. Okay, so these are some of the things that I hope you'll take from the talk. First, I want you to learn about some of the causes of mood disturbances in a serious chronic illness like ECD. And there are many. And I also want to say that one person can have multiple causes, and I'm going to make some important points about that in a little while. We're going to review some of the common signs and symptoms, and then some less common signs and symptoms, which are known as atypical symptoms. Importantly, I want to introduce you to something, and that is that there is a difference between the expected grief response when someone is faced with something that's overwhelming, and when someone's feelings and emotions have gotten to the point where they're overwhelming them, and then we're looking at a potential mental health condition. I want to also help you learn that these symptoms, having depression or anxiety, can negatively impact your treatment plan, negatively impact your family, and it can even affect your physical health. And then lastly, we're going to talk about some treatment options. All right, so this is probably not news to many of you is that decades of research have shown that depression and anxiety are very common in people faced with a serious chronic disease, something like a cancer or lupus. This is especially true for people who have a serious chronic illness that is rare, because now those people have to face the additional uncertainty of having a serious disease about which little is known and for which there are few acceptable treatments. And I know many of you have mentioned that to me. People often worry about how sick they will be. Will they recover? Can they survive? What's going to happen to my family? And how the heck am I going to pay for all this expensive medical care and at the same time try to pay my mortgage so I can keep a roof over our heads, put food on the table, keep the lights on? So this I think is an important stressor in people living with EECD that Dr. Estrada and I heard every week. And so I want you to know that we acknowledge that. We also want you to know that the grief response is an expected response when you have to live with a serious illness. And that is something that a person has to work through in phases. And as you pass through each phase, you can be anxious, you may feel depressed, you may be in denial at some point, you can get angry, but over time, the person is able to pass through the phases and then they come out on the other side of that. But while you're in the midst of that, it's very hard. And lastly, please do not think that if you feel this way, that this means that you're weak or weak-willed or that you're crazy, which people have said to us. That is not true. This only affirms that you are human. This is a human response to an overwhelming situation. Okay, let's shift gears. We're going to talk about some of the causes. Now, remember, as I'm talking about causes here, I'm not talking about all causes, and I want you to know that someone can have more than one cause going on at the same time. So take a look at the picture here, the picture on the right of the, sorry about that, it went up. Take a look at that giant wave. I had a patient tell me on his first visit that when he became ill in such a short time with ECD and he wasn't able to function physically, lost his job, had a lot of trouble in his personal life, lost some friendships too. It felt like he was hit by a giant wave and knocked completely on his back, and he was still struggling to get up. So I think that's an image that I just want you to keep in your mind. It is normal to feel that way. Now, some of the challenges that we saw that people with ECD face, firstly, is the significant loss of physical functioning that some people can experience, especially if you have disease activity in your brain. So I had a person say to me, Kevin, I could play 18 holes of golf, and I was proud to say that I could do those 18 holes of golf without a cart. And then after a full day of golf, I could rush home, take a shower, get dressed, and spend an evening out with my family. I went from that to now I need help being able to walk. I need help from getting out of the chair into my bed, and I can't work. Other people would say I would work 8 or 10 hours and I would just come home and get changed and be able to work in my garden, one of my favorite things to do, or to be able to go to the gym, and now I can't do any of that. That is a tremendous sense of loss to a person. So We understand that. Next is job loss. This is an important area. With job loss comes loss of vital income and often health insurance loss. And we here in the US, we do not have a safety net system of healthcare that is available in other countries. So this situation can create tremendous monetary stress. People will sometimes be faced with having to make very difficult decisions, which is to pay for the medications and pay the co-pays and so forth for treatment, MRI tests, which are all very expensive. How am I going to pay for this and pay the mortgage and pay for food? This is I think an underappreciated area of stressors that people with ECD live with. And there are resources to help you with this. Lastly, as a person is going through all of this, a person can lose their sense of self-worth, their sense of who they are, because we, especially people who live in the US, we often define ourselves and we show our worth to others and to the world as a whole by the kind of work we do. And of course, that we're able to earn money and live in a home and have a car and take care of our families. And also the physical things we do, like the patient who was very proud to say to me that he could play 18 holes of golf and walk the entire course. And all these things are lost all in sometimes in a very short time frame. That can create an identity crisis, and that can then lead to a mental health issue. Other important psychosocial causes would be a change in an important relationship. Chiefly among them is a marital partner or a significant other. The primary partner often becomes the main caretaker and the advocate too. So the primary partner may not only try to have to physically take care of the patient, they have to juggle the medications and run to the pharmacy to pick things up. They have to call the doctor's office to make an appointment, make sure that the co-pays were sent in, schedule MRIs and PET scans. Now, while all this is going on, the primary partner may also become the sole income source, in addition to being the full-time caregiver. Now you can see that you can have two people who are overwhelmed. And this situation can cause a change in a relationship that started out as an intimate bond between two equal partners and now has changed to a relationship of a caretaker and a dependent. And that sometimes can be an irreversible change, let's say, but it certainly is a stressor. Other important relationships can be affected too. A patient once told me that one of the most difficult things that he ever had to accept was to have his adult daughter help him from the wheelchair onto the commode. And that was not the role that he was accustomed to between a parent and a child. Those roles sometimes get reversed, and that's hard to accept. Next is the loss of one's treasured friendship. I'll give you another example of a patient who told me that he had a friend for more than 20 years who was a very close friend. They had gone through many things together in their life. But when he became seriously ill with ECD, this treasured friend backed out. And that was painful to lose a good friend, a friend and someone who throughout the course of your life, you have been able to depend upon. And now they're gone and you're struggling to understand why. Also, for people who can't work, there's also the loss of peers, and that peer-to-peer interaction that you once had was a sense of pride for you that you were able to work together and solve problems at work. And so what's happening over time is your social circle is getting trimmed back, even though you don't want that to happen. That can create great stress. Now, some people, of course, may have had a pre-existing mental health condition that was not properly addressed. And then when they become sick with an illness like ECD, the pre-existing mental health condition can get worse. It's also important to know that the symptoms of a mental health disorder can present differently after a person has become ill with a serious illness than the symptoms were before they became ill. And this is why it's important, please tell your physicians about any pre-existing mental health conditions you had before you became ill, what the treatment was, so that can be taken into account with your treatment plan. Okay, next I want to say that some medical complications of ECD can cause psychiatric problems. I'm going to list some of the common ones that we saw. And I'm going to start with some things that we saw that have to do with changes in the structure and function of the brain. The first condition is pseudobulbar affect. It goes by the acronym PBA. And this is a condition that can cause inappropriate, unprovoked, and uncontrolled emotional outbursts, most commonly crying and laughing, though crying is more common. The point is that these outbursts are not something the person can control. They are not, they do not feel the same. The person does not have those feelings inside that matches with whatever the emotional expression is. And so there is a disconnect there. And that disconnect between how the person feels inside and what they're expressing can cause great distress, because the person knows that's not the appropriate emotion to express at that point in time, but they can't help themselves. All right, that's very distressful. Sometimes people might express an emotion that's opposite of what is expected. And we want you to know that there is an effective treatment for this, but you need to be tested for this. Next, there can be dementia-related mood and behavior changes. And we have especially seen this in people who have global atrophy in their brains. These changes can be similar to what is seen in an Alzheimer's type of disease. Lastly, and rarely, there are some types of seizures that can result in disturbances of mood or even disturbances of thought. And these are due to abnormal electrical activity in the brain. Okay, another very common set of medical issues with Dr. Shikar mentioned a little bit earlier are what he called hormonal woes. So here, what I would like to point out three things. Low thyroid function can cause depressive symptoms, and they can also cause some changes in behavior too. low testosterone level, especially in men, and many people here in the audience can remember having conversations with me about that. This can have a devastating effect on your mood. People can become very fatigued, physically weak, concentration difficulties, mental slowing. And then for some people, they may have a severe adrenal gland dysfunction. This is not common, but it is something that we have seen. Now, next, I wanted to say that there are medications which can also cause mood changes. And this is not an exhaustive list, but I'm just going to say that corticosteroids is a class of drugs that includes prednisone, which you may have heard of or tried. Alpha interferon is a definite culprit in causing mood and behavior changes. And in some people, pain-killing drugs like opioids. Lastly, I'm going to finish this slide by saying that poorly controlled pain in ECD has got to be it's among the top 3 things that causes stressors, mood disturbances in people with ECD. When we think of the bone pain or the pain in the lower extremities, it makes it difficult for people to walk. I've had people say that they can't sleep at night because their legs ache and hurt, and they take a pain pill and it just doesn't help. That chronic pain, day in, day out, can lead to loss of sleep. And as we heard from other speakers, sleep is crucial in healing. And if you're chronically sleep deprived, that's going to lead to mood changes, depression, people becoming very irritable, maybe even short-tempered, and also people can become physically weak. Now, there are some other things that I'm going to mention at the breakout session, but what I want to say here at the end of this slide is that the treatment for medical causes would be different and therefore should be something that is targeted to what the underlying problem is. Okay, so we're going to shift gears again. We're going to talk about some of the common signs and symptoms. So for depression, we're looking at someone here who has a persistently depressed mood. So we're not talking about someone who feels sad for a small portion of the day. We're talking about someone who's persistently depressed throughout the day, through most days of the week, and it's just hard to make them feel better. Another important symptom in the second bullet point here is someone who loses interest in activities they once really liked. And it almost sometimes it doesn't seem to make sense because it might be an activity like reading or working with a simple hobby that doesn't require a lot of physical exertion on the part of the person. So you may say, gee, although they have fatigue, they used to love to read, and now they don't even want to touch a book anymore. Next, we have sleep loss, which I touched on. But here, what we're looking at is loss of sleep that is not due to another obvious cause, such as pain. That's difficult to tease apart, which is why we need you to work with your doctors so you can find out what's causing what. Some people will just lose their willingness to eat or their desire to eat and then lose weight. Again, here, we're not talking about someone who's lost their appetite because they're experiencing nausea due to a side effect of a medication. It was common for us to see people who come in who were uncharacteristically non-compliant with treatment. This was a person who would typically be on top of things and now instead had said to me, Kevin, what's the point in trying to take all these meds every day? I don't feel like I'm getting better. So I would rather just sit here. Then on the other end of the spectrum, people can become very restless, agitated, anxious. People can pace up and down the hallways of their home, or I saw people pacing back and forth on the floor, and they couldn't stop. They were constantly fidgeting with things. And then I have also seen people have panic attacks. Now, not everyone has the common signs and symptoms. Some people will have symptoms that are kind of the opposite of what we've just described. We call these atypical symptoms, but they're important symptoms to watch out for. So let's go over some of these. So first, a person can exhibit uncharacteristic agitation, and their temper can be very short, as opposed to what you typically think of in a depression, in which you have a very melancholic affect. Some people may overeat and inappropriately gain weight versus losing their appetite and losing weight. Some people may wind up sleeping too much, which is called hypersomnia. I have had family members tell me that their loved one sleeps easily 10 hours a day, more commonly even 12 and sometimes up to 14 hours a day. And then there are other symptoms, which I'm going to discuss more at the breakout session. All right, so before I get into the content of this slide, I want to reiterate something. The expected grief response is a normal response to an overwhelming situation. That's expected to occur. That in and of itself can be devastating with all the symptoms and feelings you're going through. But there comes a point when the expected grief response is not something the person is able to work through, and the signs and symptoms begin to overwhelm them. Okay? Here, I'm just going to list some of the clues here, some of these signs. First, when your symptoms begin to interfere with your ability to function, and I'm not talking about playing 18 holes of golf, okay? I'm talking about your ability to be able to organize your thoughts so that you can organize your day, to remember to take your medications, to be able to perform these essential tasks of self-care. A person who's no longer able to concentrate because they are so anxious, they just cannot think straight. And especially people who begin to persistently withdraw even from those people who they love most. Next, as I just mentioned, some people I've known some patients who had multiple panic attacks over the course of a day. And that is very disruptive. They couldn't even organize themselves to be able to eat. So these are all signs that you have transitioned over to a point where you need more formal assessment. Lastly, I want to say that on this slide, there are two things that require urgent attention. When a person becomes preoccupied with thoughts of death, with thoughts of ending their own life, that requires immediate attention. I had a patient say to me, Kevin, my life is not worth living. My family is better off without me. And when I began to talk to that person, they began to tell me of some plans that they had been trying to think about in their mind. That's an emergency. That needs help. That person needs help right away. But on the opposite end, which is what we may not see very often, is a person who begins to act out, and sometimes physically, where they may be a threat to others. And those people need help right away too. All right, thanks. And so what we want you to know is that help is available. And it starts with you telling someone how you feel. All right. Work with your doctors to be able to look for medical causes, because someone may be depressed on an antidepressant, not getting better, and it could be because there are other causes that need to be discovered. That said, medication therapy can be very effective, but it takes time to work, and that's why you need an organized treatment plan. So we think that talking therapy is very helpful. We would say that you should work with someone who is trained in working with people who are dealing with mental health disorders secondary to medical illness. One of the most effective things that you can do is to join a support group. And in that way, you are not isolating yourself. I'm going to talk more about further testing, more formal testing during the breakout session. We need to talk to you about being, you hold the key. Be proactive, learn self-care techniques. We're big fans of PT, OT, and speech therapy. I'm going to leave you with these parting thoughts. It's okay to feel overwhelmed. Admit how you feel. Don't say everything is okay when it's not. Don't isolate yourself. Get involved. Tell your loved ones thank you for all of their hard work. These are two pictures that I want to leave you with here. And I just wanted to say thanks to a whole bunch of people who have come before me, and without whose work I wouldn't have the opportunity to speak, and to Kathy Brewer, without whose selfless dedication, none of us would be here. So thank you. And because we're about to go eat, I'll take the questions at the breakout session, all right? Happy to help.